Transitioning to our second panel, federal health policy, big changes at the CDC, FDA, HIH, and HHS. It is my pleasure to introduce Julie Rovner, and she is the Chief Washington Correspondent for KFF Health News, and I encourage you to look at her impressive bio, and more importantly, to read many of the stories that she's written, possibly catch her podcast. It's my distinct pleasure. Thank you, Julie, for coming.
You guys want to come on up? Good morning. I am so happy to be here. I'm a little bit sorry it's not a little bit warmer, but at least it's pretty. As you've heard, I'm Julie Rovner. I'm Chief Washington Correspondent for KFF Health News, where I also host the weekly health policy news podcast, What the Health. I am amazed to be here today with this really incredible panel. I'm going to give you a little bit of a warm-up first. Last Friday marked a year since Robert F. Kennedy Jr. was sworn in as the 26th Secretary of the Department of Health and Human Services. And no matter what you think of what he's done, it's been a year of very big changes to the cabinet department that oversees the biggest budget in the federal government, including programs like Medicare, Medicaid, the Affordable Care Act, the Children's Health Insurance Program, as well as the entire U.S. Public Health Service. And that's just the health side, not even the human services side. When RFK Jr. took office, HHS had around 80,000 employees in and around the Washington, D.C. area where I live, in Atlanta, home to the Centers for Disease Control and Prevention, and throughout the country, from the Florida Keys to the Alaskan Aleutians. As of January 2026, according to the Office of Personnel Management, that's down by nearly a quarter. In terms of numbers, the biggest reductions have come from the National Institutes of Health and the Food and Drug Administration. In percentage terms, the CDC is down the most at roughly 25%, compared to 21% for the FDA and 18% for the NIH. Not all of these people were laid off, of course. Many retired early, having been offered buyouts by Elon Musk's Department of Government Efficiency, or having simply quit when pressure to pursue President Trump's agenda got too much. I should add here, this is not at all normal. I have covered administrations run by Democrats and Republicans over almost 40 years now, and the normal thing is for political appointees to leave with the outgoing administration, but for career workers to stay in their jobs. That was the entire idea of a nonpartisan civil service. So were there more people than were needed to do the work of the department? That's been the charge. Some would say yes, some no, but it's clear that many, many decades of scientific and medical expertise has now left the buildings at HHS, and the full consequences of that, I think, have yet to be realized. It's not just personnel, of course. The department in 2025 canceled thousands of grants and contracts, some because they were accused of pursuing now banned diversity, equality, and inclusion missions, others because, well, it was not always clear why. Some of those cuts were restored as a result of court rulings. Others, including a sudden multi-billion-dollar cut to the Substance Abuse and Mental Health Services Administration, were reversed just as abruptly as they were announced. Not clear if that was due to political backlash from Capitol Hill or perhaps somebody jumping out a little too far ahead of their skis. Meanwhile, the newly reconfigured Department of Health and Human Services under Secretary Kennedy has pursued some, shall we say, different goals. One, as Dean mentioned, is to reshape the way the American public eats, which actually has some significant bipartisan support, although Kennedy doesn't actually oversee as much of the American food supply system as he would clearly like. Another goal is to change the nation's attitude towards vaccines, something that puts the secretary very much on the opposite side of most of the medical mainstream, some of whose representatives are suing him in an effort to overturn the anti-vaccine efforts of his hand-picked Vaccine Advisory Committee. The reverberations from these sudden and dramatic changes extend far beyond the federal government. Drug and vaccine companies are rethinking their investments in the face of a newly unpredictable FDA. Biomedical researchers are decamping to Europe and Canada and even China in some cases to pursue their careers. Universities are in a state of limbo, wondering whether critical research funds will or won't continue, making it difficult for them to plan even a year in advance. So is this good or bad for the country and our healthcare system at large? I'm sure our panelists will have opinions, so let's turn to them now. You have their bio, so I will keep the introduction short. And before we begin, here's how we'll do this. Each panelist will talk for about 10 minutes, and then I will ask some questions, and then we will turn to you, the audience, for your questions. We're going to start with Andy Lipstein-Friedstadt, who's Chief Strategy and Public Policy Officer for the Parkinson's Foundation. Andy previously served as Deputy Director and Chief Strategy Officer at the U.S. Centers for Disease Control and Prevention, and before that was a Deputy Commissioner at the FDA and has also worked on Capitol Hill for the Senate Health, Education, Labor, and Pensions Committee. She'll be followed by Stephen Parenti, who's the Minnesota Insurance Industry Chair of Health Finance at the Carlson School of Management at the University of Minnesota, and Associate Dean of the Carlson Global Institute. I'm sure he thinks it's very warm here. Steve is also the president of the American Society of Health Economists. Previously, Steve worked at the White House during President Trump's first term and at the Department of Health and Human Services. After our first two speakers have presented, we'll have two responders to talk about what's happening outside the government as a result of the changes at HHS. First is Michael J. Stamos, Dean of the School of Medicine here at UC Irvine. Dean Stamos has served in this role since 2016 and comes to Irvine from up the freeway at UCLA, where he practiced as a surgeon and chaired the Department of Surgery. Finally, we'll have Kirsten Axelson, a senior policy advisor for the global law firm DLA Piper. Kirsten brings more than 25 years of experience in life sciences and was previously on the leadership team of Pfizer's global innovative pharmaceutical business. So we will start with Andy. The floor is yours.
All right, good morning, everybody. It's great to be here with you today, and a big thanks to the Center for Healthcare Management and Policy for inviting me to join this really fantastic panel. As you heard, I'm Andy Friedstadt, Executive Vice President and Chief Strategy and Policy Officer at the Parkinson's Foundation. And Julie and I were talking on the shuttle ride in. It is quite a week to be talking about changes at HHS. You could say that a lot of weeks, actually, but this week maybe in particular. So I want to spend a few minutes talking about some of the changes that we've been seeing, what helps federal agencies thrive in general, and maybe a little bit about what the road ahead looks like. And we'll see. There we go. Okay, so this session is, as you all heard, is focused on big changes at HHS, but I want to spend just a minute sort of laying the groundwork about sort of when we talk about public health and health policy, how important it is to look at the full landscape. The changes at HHS have been really significant. You heard a little bit about that, and I think that's not any question. But the ways in which these changes will impact people and communities really depends on the entire health ecosystem, of which everyone in this room is part. This Venn diagram leaves out many, many key circles, the courts, industry, academia, states, many others, but is some of the perspectives that I want to bring into this conversation today. I'm talking to you today from my current perch at the Parkinson's Foundation, where I spend a lot of time thinking about and working to influence the way federal policy matters for people with Parkinson's disease. But for much of this morning, I'll be wearing my hat from my former agency positions that you heard a little bit about, as well as a former Hill staffer. And I should note, I'm sharing my own opinions while I'm wearing those hats. So, as you heard from Julie, I spent about 4 years in the executive branch atop CDC and FDA. And the thing that's most important for this conversation about those roles is that in both of those roles, I oversaw agency policymaking as a whole, first for FDA and then for CDC. And there were lots of changes in those 4 years, but there's no question, as you heard from Dean, that the pace and the nature of the changes that we've been seeing over the last 13 months are really without precedent. Prior to joining the executive branch, I served on the Hill with the Senate Committee on Health, Education, Labor, and Pensions. And I want to also talk a little bit about the ways in which Congress is engaging or not engaging on HHS changes, how important that is, because ultimately, again, that's what really matters in terms of what the HHS changes, what reaches community, what reaches family, what reaches industry. So this isn't a panel about Parkinson's disease, but I want to just briefly highlight some of the priorities that we're working on at the foundation as a way to sort of give an example for what these changes mean for one community in particular. Parkinson's is the fastest growing neurodegenerative disease, more than 1.1 million Americans living with Parkinson's, 90,000 new people diagnosed each year, yet no cure, and too many people experience delayed diagnosis and uneven access to care. So here's what our work is focusing on now today. Increasing research support for better treatments and cures. We've already talked a little bit about research funding, and it's both the dollars that Congress appropriates and then what HHS and its agencies do with those dollars, strengthening care systems, including for the most vulnerable, expanding access to high-quality education tools and resources, and promoting prevention strategies, including efforts to reduce exposure to environmental threats like the herbicide paraquat, which has been tied to Parkinson's. And HHS decision-making is hugely consequential on each of these priorities, and you could have someone up here from a million different organizations that would be able to speak to these same sort of consequences. So we're thinking about certainty in research funding and policies. I think Dean's point about predictability and how important predictability is to the ecosystem is really important, and and sort of the extent to which predictability is or is not the goal right now. We're urging HHS to seat the first ever National Parkinson's Project Advisory Council. That's something that Congress called for on a bipartisan basis, but hiring freezes and other changes have impacted. And seeking to understand the status of programs that are critical to the health and future of patients across the country. So you'll be hearing some from my colleagues about changes across the agencies, but given my experience, Julie asked me to focus a little bit on CDC. And as you heard, there's been huge changes across HHS, but CDC has faced some of the most large-scale changes. Due to a new law, which was passed actually during the Biden administration, for the first time right now, CDC is intended to have, by law, must have a CDC confirmed director. That's new for many, many years. I'm sorry, what did I say? Senate. Yes. Senate confirmed director. For many, many years, CDC had a director that was just named by the president, but now the Senate must confirm that. Yet for this administration, the first one for which this law has an impact, they've had a Senate confirmed leader for just 29 days. Many of you probably followed the news of the quick coming in and going out of Susan Menares, who was that first Senate confirmed director. And it can be hard to keep up with who's leading the agency and the programs within it. In fact, just yesterday, news broke that Jay Bhattacharya, who many of you will know as the NIH director, would be named acting director of CDC as part of a major shakeup that's been announced this week around HHS leadership. It's not just the very top of the agency or agencies. We're also seeing a lot of vacancies and change among CDC center director positions. These are positions, as sort of Julie alluded to, that are typically held by career senior servants. So we normally see people sitting atop either the center that's focused on HIV, AIDS, and STIs, or on chronic disease, or in any of those centers. Those are normally career civil servants who stay across administrations, but we've seen huge turnovers and vacancies across those centers, and similarly across institutes at NIH and centers at FDA. And then we've seen, of course, impacts on the career civil service workforce as a whole. The administration proposed reducing CDC's budget in FY26 by more than 50%, and moving or eliminating close to half of the programs. So when you look at that 50%, it's not saying 50% across the whole agency. In many, many cases, it's proposals to eliminate or move entire sort of areas of the agency's work. Congress has blocked many of those proposals, but CDC, as you heard, has lost a quarter of its civil service workforce since January of 2025. This chart shows that 36% of branches at CDC have been eliminated at least once, some more than once. They've been eliminated, they've come back, they've been eliminated again. Though, engagement both from Congress and the courts has been consequential there. So I think it's really fair to say that the makeup of the agency, both sort of human by human and across the org chart, is very much shifting in real time. The process through which public health recommendations and funding reach the public has now sat largely outside the agency. During my time leading CDC's policy work, we really reinvented the policymaking process. So it's not my view that this is a process that needs to be static or that was exactly right. But there is critical value in rooting this work in the scientific expertise of career scientists at CDC. These changes are also especially consequential for state and local public health departments. Historically, 80% of CDC dollars goes directly to states and localities. So these are the health departments that are on the front lines of everything from chronic disease prevention to preventing outbreaks. And these state and local entities are also looking to CDC for guidance and expertise. So I think it's easy to think about this as something that's just sitting in DC, or in the case of CDC, sitting in Atlanta, but really the very, very clear ties directly to what's happening at states and localities. We're also seeing changes related to many of the data systems at CDC. Many of you will know CDC's long been a critical source of public health data to inform responses and to efficiently direct resources to health threats. Trust in this data plays a really important role in how people and communities make their own decisions about health risks and those threats. And so many in public health are really closely watching those data systems. One data point, so to speak, at the beginning of 2025, CDC updated 82 databases, at least monthly. By the end of October, close to half, or 38 of those, had been paused. So there's just less visibility into what's going on. While agencies like CDC and USAID have been sort of on the forefront of changes, I'll spend just a minute talking about FDA and NIH, and again, I think you'll hear more. Federal funding cuts at NIH risk stalling progress, ending clinical trials prematurely, and closing the door to potential life-changing and even life-saving treatments, both for people living with diseases today and for those in the future. Congress has largely rejected the administration's proposals to cut NIH funding. In fact, we just saw, as you heard briefly, Congress actually say, we're going to increase NIH funding by $415 million rather than taking the proposals for cuts from the administration. But we're continuing to see issues with dollars being impounded, which is to say not being spent even once they're appropriated, trials being disrupted or delayed, and continuing uncertainty with research planning. And at FDA, which is a sort of notoriously stable agency, some might say stable to a fault, there are huge changes. The largest center, CDER, which regulates drugs, has lost 20% of its employees in a year. That's more than 1,000 people with very specific expertise. And we don't know really what that's going to mean for the potential for missed deadlines for applications, possible delays in drug approvals, or impacts of inspections of facilities. So I want to just spend a minute stepping back and saying, what have we seen over the years helps agencies succeed? And I think it's a really helpful lens to sort of look across these different areas and think about what changes might mean. So 5 of those that I want to just spend a minute talking about. The first is around sustaining and growing federal investments. This is really about making sure that agencies have the dollars they need and are spending the dollars they have to do the critical work. 2, ensuring agencies have robust tools and authorities. This is both authorities granted by Congress and the ability to really exercise their own authority in ways that are science-driven and evidence-based. Clear and transparent communication. We know how important that is to building trust. The best and the brightest workforce that's really thinking about the talent that we need to have the strongest possible Department of Health and Human Service. And then patient-centered regulatory processes that are rooted in science. You know, in my current role, I do a lot of work bringing the lived experience of people with Parkinson's into the policymaking process. And agencies need to be able to account for this by building a big tent that transparently brings in diverse stakeholders with different views. So just a word, maybe before I turn things over to Steve, about the future. I think the good news is that we know a lot about what works. Robust, sustained, predictable investments in public health and research. We know how critical that is for saving lives. As our partnerships, again, across the entire healthcare ecosystem, defined sort of as broadly as possible, in my view, well beyond what we think of as just traditional health players. These are challenging times, unprecedented times, for some exciting times in public policy, but there's a real opportunity with that to reimagine what's possible. The federal and state policy landscape gives us an opportunity to make short and long-term changes to strengthen public health and healthcare for years to come. There's a critical opportunity for advocacy in shaping the path forward. I think we heard that question about what can be done, and there's a lot that I think can be done. And it's as important as ever to capitalize on common areas of agreement. For us at the Parkinson's Foundation, for example, we've been heartened by the attention that the MAHA movement has brought to toxic chemicals and their ties to many health threats. We heard a little bit about food as an area of some common agreement. So really working to drive alignment where it's possible. And then taking a look at the big picture and just really thinking about the pivotal moment we're in scientifically and how best to leverage that. And we know that a strong, predictable HHS is really critical to that success. So I'll stop there. Thank you very much, and looking forward to the discussion.
Thank you. Let's see, I think I have some slides here too, actually. Let's see what happens. Or maybe not. Oh, I do, okay. What do you know? So first of all, thank you to the Center for Healthcare Management and Policy. Thrilled to be here. Great to be in a business school too. And even most importantly, coming from Minnesota, it's really cool to see liquid water. It's been a while. So thank you for that. It's really uplifting. So I'm going to take a different riff into this. As people mentioned, I worked in previous administration, sometimes talk to them. If you haven't seen it yet, this is something that came out 2 weeks ago. It's the Great Healthcare Plan. It has all the different elements that are there. This is all there is, by the way. There's not a page beyond it. But there is a lot of detail beyond it. I can tell you, without too many confidence, that the president actually named this. There were actually 20 choices in front of him, and he rejected them all. And this was the choice he came up with. So these are the things that are inside that program. So basically, as we've talked about before, and Dean Rosen did an incredible job really laying out the landscape in a tremendous way. Pharmaceutical prices is a major area. The thing to understand about the president is that at his heart, he's a populist. Up until 2015, he was a Democrat. He basically feels that drug prices are just too expensive, and he would be probably talking to my late uncle at the Italian American Club about that while watching Fox News. That's pretty much where he is. And so when he's talking to the staff, like, how can you make this work better? The idea of making deals through tariffs is a little more nuanced that he figured out for Trump too, but that's kind of where he is. Lower insurance prices, we've seen this come through in different ways. The rate notice for Medicare Advantage was a shock, though that's a notice of proposed rulemaking, which is inside baseball, but it means it's not final yet. But what I'm going to focus on is sort of, if you will, a story and a parable of my 10 minutes here. Of transparency. It's an area that I got involved with quite a bit. My training is in health economics. I've actually done research in transparency for not quite since 1990, but almost feels that way. And I actually have sort of, if I go New Testament, so sort of a Saul to Paul conversion. I didn't really think this would actually do anything. I've gotten research dollars on it, but I kind of think that it might, but it's going to take a lot of pieces to come together. So this journey, if you will, in Trump land started in 2019 with an executive order that basically more or less outlines what can be done. And what the big piece of it was essentially to require the insurers to actually disclose all their negotiated prices. I used to work in the insurance industry before I was an academic. It was sort of interesting to be in the White House and essentially giving the parts list. If you remember the movie Matrix, Dean Rosen, I'm a big fan of movies too, when they basically go into the weapons room and they're like, weapons. And for me, it's sort of like, I want these 5 fields, these 5 data fields, please. Why do we care about this? An article I did when I was working the chair of Healthcare Cost Institute, there are big price variations. Everyone talks about Medicare being cheaper. Interestingly enough, it's cheaper in Minnesota, but actually commercial is much more expensive in Minnesota, which is a target income hypothesis of providers that we're seeing. This is an exact mirror image of the Dartmouth Atlas, if you remember that from Medicare costs. Here's another factor. High deductible health plans, basically large deductible health plans, have been growing. They were really, with HSAs, there were nothing in 2004. Now they're basically, depending on how you count it, it's up to 60 million accounts. They've become the fastest growing design, though not as dominant, obviously, as PPOs. It has also a major, if you will, transparency has a major constituency behind it. Anyone who've ever encountered Cynthia Fisher, she is really quite formidable. She has started this patientrightsadvocacy.org. She's had Susan Sarandon as a major advocate for this. It's a bipartisan issue. She's been in the Biden administration, she was the Trump administration, and she's probably, I would say, the person that actually got this across the finish line to get the executive order to even happen in 2019. And here's a big question, though. This is actually a picture of Minnesota. I like this picture because it shows that there's grass and not snow. And actually, when I left yesterday, the grass was going, like there was rain as I was leaving, and my wife told me it's like the snow came back. So it's sort of like more of a groundhog thing. So the question is whether or not consumers are ready for this transparency. All these people are putting all this energy. Economists think it's interested. Are they ready? Or are they interested? So this is actually a study that was done around the same time. Basically a survey, Larry Van Horn and Art Laffer, as in the Laffer curve, Art Laffer. And it does show that price is the big difference if it's primary care, knees, newborns, in terms of what people look for in terms of choosing. Now, granted, some of these things you may not have any choice at all, but if you have a choice, if you have the time to make the choice, this is what is important. But there's also this question about, should you even care about the price? And the thought is, if I have insurance, that's the best price. I don't even have to shop. It's fine. That's almost 50% of people in terms of where things are. And in political economy, if the median voter isn't moved, you're not going to get anything. And so what's even worse is that 78% don't think the price is less than 2 times, which actually I can show you the prices are basically 600% spreads. It's a pretty major area. In this. And so when you have a large majority of the population, not even split, doesn't even realize that there actually are differeses, and why would they? With $5, $10 copays. Think what you will about Kaiser, it's an incredible institution, and actually from Minnesota, Paul Elwood popularized the HMO Act 1973, basically saying everybody should get prevention, but that would mean if it was a regular car insurance contract, that our tires, our wipers, our oil is also paid for $5 too, as opposed to, $2,000 for tires. Then here's the other question. If they were ready, what might be the impact? Well, you want $1 trillion? Here it is. So I basically published a study and inquiry hoping that this might catch on, made a forecasted estimate based on some of the price differences between cash taking patients, their prices, which are about 40% on average cheaper, and said, in 2025 alone, that's last year, I wrote this in 2022, I think originally, $80 billion. I was very hopeful. And then I thought it was over 10 years, CBO types of estimates, $1 trillion. And so when these prices first came out, the insurers had to put them all out. Every insurer, not just individual, but employer-sponsored as well. Wall Street Journal documents in 2022. And excitingly, again, back to a media reference, these data, actually just 1 month of the data is bigger than the entire video libraries of Netflix, Amazon, and Apple. Which is crazy because all we were asking for was 5 fields, okay? CPT-4 code, prices, NPI codes, et cetera, et cetera. So the insurers, and I grew up in that world, they're very clever, and I give them, they basically complied with the law, but they also made it really interesting. And how did they do this? So this is just United Healthcare, local to Minnesota. These are the files for June 2023. You can download them. They're in JSON, they're not text files, so it's a kind of a complicated file to download. Sometimes they're a terabit in size. Here's file 1. It actually are detailed to specific employers as well as individual plans in no particular order, not even alphabetical. That's file 1. Here's file 3,999. Okay, now if you actually look today, I actually looked yesterday in 2026, they come out monthly, by the way, brand new prices. It's up to 65,143. So if you want to do this for a living, you have to download this every month for every insurer to get that transparency in prices. So, and the interesting thing is well, who's getting the data? Well, it turns out not the consumers, but the industry is using it. So the basically whether it's consultants or whether or not it's hospitals and others, they haven't made the investment to do this. And that was not the intent. I can tell you from the administration, I can tell you from actually talking to the president, this was not the intent. Many of the people at Dean Rosen that are back from Trump 1 to Trump 2, this was certainly not the intent. So then here's a little pivot. Again, this is actually showing that the Mississippi does unfreeze there. That's our skyline, but also with grain mills there too. So I'm going to make a movie reference as well from Looper. Great movie, a lot of time travel. You have to watch it like 5 times to really understand what happened. And so my attitude about this is, so I changed it. I just got frustrated in this space. And so what did I do? I made a company. Now, full disclosure, I got to be careful about these things. I own my MedVita. I actually came up with this notion way back when. I think I bought the URL, oh my God, in like 2012, not 1990 at least. And so I have 4.6 million shares at a value of like less than pennies, and so it's $4.60. Anyone wants to make an investment, just let me know. But you can actually, this is actually out there, it's real. We actually built, we used the transparency and coverage rule, we downloaded all that data, we basically got a Minnesota supercomputer, which is where Cray Computers comes from. It took a supercomputer just to unpack those files, and it takes a month, literally, to get 1 month of files in any way, shape, form to be able to do it. If you did this through Amazon Web Services, the usury cost is about $100,000 per month just to download it, let alone uncompress it. So bravo, insurers. We then basically decided, like, put this onto a smartphone, because who really goes to the web anymore? Because we live on our phones. It's a great consent tool as well. And you can just, if you want, remember the name, My MedVita, if you want My Medical Life, that's the ambition of it. It's on Android, it's on Apple, it's free. Try it out. But what I want to show you is at least one example for why I think consumers should care about this. There are 70 million HSA consumers out there today. That's a lot more than people ever thought there were ever going to be. And here's a real world example. I looked at a hospital in Camden, New Jersey. Someone published essentially their EOB, their explanation of benefit of what they were paying for an MRI, which is amazing. The negotiated amount was basically $4,900 for a brain MRI, which is way too much generally. If you go to the app, what you would find for that same Camden hospital, recent data is as low as $260. Actually, Medicare rate is about 20% lower than that. But then you would also see, if you look over toward on the right side, I know it's sort of hard to see, you see this one person, Joshua Kellerman, and he has different prices for Aetna. Actually, all these are Aetna. These also have Blue Cross prices too, but they start at $260, but they go all the way up to $1,600 for the exact same CPT-4 code at the exact same address. Why? That's crazy. That's beyond the $5, $10 copay aspect of it. Go download this thing you want, play with it. It amazes me. We have 500,000 providers on the system, and basically only 70 shoppable codes, because that's about all the supercomputer can handle before it gets sad. So if someone actually were to save that money, like an average person, and they let it just grow in their HSA account at age 35, that's $35,000. That should give them incentive to care. And actually, who might care? So the one agnostic category in this whole area, thinking about this, are the banks. And granted, not all the banks are in this anymore. The largest one is Health Equity, which is really a specialized HSA bank. But Fidelity is in this market as well. It turns out the average HSA balance today is $3,500. $1,200 is what the spend is on that. If you just took what we found from that article I published at 40% savings, figure only 20% of the population is going to care. Remember, 78% seem like they don't know what actually is going to happen. You put all those dollars together from a insurer PM per member per month perspective, that's like $8.80, let alone the money that the banks get to retain to reinvest in other things. Everybody has an incentive to play along in this. And why do I bring this up in the context of finishing this all out? Because President Trump's the only person who actually talked about health savings accounts, even though George W. Bush passed them. And it's an active policy conversation. Dean Rosen mentioned that might be in play. It could be a way, actually, to make the enhanced subsidy money that people want to have go to those accounts, move it around, and get people more engaged. It'd be one thing if there was no health savings accounts in the world and no one really cares, but with 70 million people, you might actually care in terms of what's actually moving. So what lies ahead for 2.0? Basically, we could talk about this in Q&A. There's quick wins that people want to see. It's a very populous place. MAHA is a populous thing. The drug part is a very populous component of it. Transparency arc, what I'm trying to show you is that it's not a quick win. It's not easy, and the engagement that people want to see with the consumers is actually kind of a big fail. We kind of, You know, if in a business school, when you actually say we have a $5.1 trillion economy, we celebrate that. Here we think it's a funeral. You know, $3 trillion is what we spend in housing. $3 trillion is what we spend in leisure. Another $3 million is what we spend in travel. Do we talk about that like that's a failure? No. It's celebrated in CNBC. So I think, you know, one has to take into context as to, like, we know there's inefficiencies in this system, but we're not going to take it to zero. We just have to figure out where most people get the value out of it. And if people don't even realize as consumers that they should at least shop a little for the marginal things, not everything, but enough, then I'm not sure how we get to the right place. But I have hope. That's why I still stay in this. So I welcome all the conversation that we're going to have, and I thank you again for the opportunity to visit with you today. Take care.
Good morning. Good morning. I'm Michael Stamos, Dean of the School of Medicine here at UC Irvine, and it's a pleasure to be here this morning. I want to give my disclaimer. I don't have an app. And not even worth that much money, or that little money. But I am colloquially known as the eternal optimist. So I'm going to give you that disclaimer. So you will hear from me is a degree of optimism that might seem out of place with reality. And it was only reinforced, if you would, by the fact that on my drive-in this morning I saw a beautiful rainbow. So it's really an honor to be a part of this esteemed panel. I'm the third dean of the day so far, I think, if I'm keeping track. But I really appreciated the prior two deans' comments. Over the last decade, as dean, I've witnessed Orange County's healthcare and life sciences ecosystem really transform into a national model of innovation. A transformation driven not by chance, but really by willingness to embrace change, invest in talent, and push the boundaries. What I think makes this forecast, this conference special, and I've been attending for the last 10 plus years, is that it brings together diverse perspectives like we've already heard this morning. Business leaders, healthcare executives, academics, and even some students all willing to sort of think about things from their perspective and then have frank, forward-looking conversations. This year, that conversation is especially important, as we all know. And it's been an unprecedented year of change. And everybody has seen the headlines over the last year, but really over the last month, over the last week, over the last day, literally, right? So changes in federal health policy, NIH, HHS uncertainty, reorganization. And if you're a business leader relying on biomedical innovation, or if you're an academic or a researcher dependent on federal funding, or a student considering their career options in science or research, you're probably feeling some concern, as you probably should be. But I'm here today to give you, I think, three important messages. First, academic health systems like ours are the foundational R&D engine for the biomedical industry. And that role is more critical than ever. That hasn't changed, and that won't change. Second, at UC Irvine, we're not waning, we're advancing. We consider ourselves, and we call ourselves, a forever organization. We are trying not to be overly reactionary. It's hard not to be, but it's important not to be, to look at the future, because this too shall pass. Not that things are going to be the same ever again. That's not my point. But this too shall pass, this degree of uncertainty and instability. But we continue to train the next generation of scientists. We continue to develop new partnerships with federal agencies and support industry that brings tomorrow's cures. Third, despite real challenges, there are strong reasons to be optimistic about the future of biomedical research and our School of Medicine's role in it. Let me begin by amplifying a point often overlooked in policy discussions. Academic health systems serve as the primary research and development arm for much of the biomedical industry, especially here in Orange County, where we have a very thriving ecosystem of biotech startups, some of which come out of our university, medical device innovators, and digital health companies, to name a few. From my perspective, I'll talk a little bit about how the innovation pipeline works, or at least should function. NIH and other federal agencies, NSF, fund our faculty and other faculty around the country for the high-risk early-stage work, the basic science that may never pay off and certainly may not pay off for at least a decade or longer. For first-in-human studies, for the novel approaches that no company would fund because they're too high-risk and too uncertain. Academic health systems such as ours transform some of these ideas, not all of them, into reality by doing the basic work, by conducting early-phase clinical trials, by developing new methods, by starting companies by collecting data, by building the evidence base, and then by training the scientists who will advance the critical work. Then, ideally, industry partners step in. Once the science is sufficiently de-risked to move products, ideas through late-stage development, FDA approval if necessary, manufacturing, and ultimately commercialization. Without that commercialization, the impact of what you've done as a scientist is minimal, right? That's a really critically important point that wasn't always recognized by academicians for the past several decades. At UC Irvine, we see this partnership every day. Our investigators collaborate with numerous industry partners on everything from novel cancer therapies to AI-driven diagnostics to advanced surgical devices. But these collaborations rest on a foundation of that federal investment in our labs, relies on our clinical trial infrastructure, and most importantly, the people that are doing the work. When NIH policy creates uncertainty, the effects extend beyond universities. It impacts the entire innovation ecosystem, affecting new products, companies, and treatments for patients. So I'll just say the current environment really, to me, is about change, not catastrophe. Headlines will suggest an ongoing crisis with no end in sight, but I think the reality is more nuanced. It's true that there has been significant policy volatility. Over the past years, we've seen some pretty radical proposals, massive NIH cuts, capping indirect cost rates, changing to how grants are funded, workforce reductions at NIH, and rapid policy shifts, like the recent $2 billion in mental health funding cuts that were announced and then rescinded, I think, in 24 hours. So these rapid changes create significant challenges for institutions that are trying to plan ahead and trying to build ahead, that really plan over decades rather than fiscal quarters. But here's what's also true. Congress, on a bipartisan basis, has consistently rejected and pushed back against those dramatic proposals. The Senate Appropriations Chair, Susan Collins, recently told Jay Bhattacharya that the administration simply shouldn't propose a 40% cut to NIH in the next budget. It wasn't going to happen, and it didn't happen. The facilities and administrative cost cap that would have devastated research capacity across the country has been paused, and overall NIH funding levels have actually increased. Minimally, but nevertheless increased, not decreased. Not the same with NSF and others, but still the dramatic cuts didn't happen. And most importantly, I think the conversation has shifted from should we fund biomedical research, is it effective, is it useful, to how do we fund it more effectively, which I think is a fair question. And I think we have to participate in that process and in that evolution. And we're prepared to engage in that conversation and work through the politics to find a solution that we can all agree upon, which is really about keeping people healthy and making people healthy. Recently, we had the privilege of hosting Jay Bhattacharya here on our campus for a full day. He spent half a day at our real world data conference, where he delivered keynote address, and then spent the rest of the day meeting with leadership, including myself, Vice Chancellor Goldstein, as well as Chancellor Gilman and our UCI Health CEO, Chad Lefteris, among many other leaders. What became clear through those conversations is that he and the current NIH leadership are serious about important reforms. More emphasis on replication and validation studies, better use of real-world evidence, and ensuring that research dollars translate into actual health improvements. These aren't bad goals. In fact, they're things that the scientific community has been discussing for years. So we have alignment, as we heard earlier. Alignment is where we have to be looking for. The key question is how to reform in a way that strengthens rather than destabilizes the research enterprise in this country. I'll give you a concrete example. Last year, there was a proposal from a consortium of academic and medical organizations, including the AAMC and the American Medical Association, to restructure how indirect costs are handled, moving support from indirect, which is sort of a black box, to direct categories. And we believe, and that group believes, that if done thoughtfully, this could actually work well for institutions that are doing the fundamental work, including here at UC Irvine, that have invested heavily in research infrastructure to allow us to make the advances that will take a decade or two to see. But if it was implemented as a sudden shock rather than a planned transition, it could force universities to subsidize research from clinical margins or cut capacity. And as we're hearing from Stephen and others, those clinical margins are also being threatened. And so it is really a circular argument to some extent. But again, the difference between reform and crisis is stability and partnership. And at present, I am, again, cautiously optimistic that we're moving towards reform, not crisis. Where does our School of Medicine stand? We're in a position of strength, and we're taking proactive steps to remain on top of the situation. I'll give you some specific examples. Despite what's happened in the federal government over the last 12 plus months, our research portfolio has continued to grow. We've had a few threats, we've had a few grants taken away and then restored. But we remain committed to ambitious science and are investing in areas where we can make unique contributions, including AI, precision medicine, real-world evidence studies, health equity research, novel cancer therapies, gene editing, and regenerative medicine, just to name a few. We're also relatively well-positioned financially, thanks to successful philanthropic support from the UCI's Brilliant Future campaign, as well as major gifts to our Alzheimer's, Memory Impairment and Neurologic Disorders Institute, and gifts to establish a Depression Institute. We have the resources along with our diversified portfolio. We invested not quite a decade ago in our clinical trials infrastructure to be sure that we were not completely dependent only on federal dollars to support basic research. Thanks to these successes, we're not solely dependent, and therefore we have resilience and flexibility. We're also leading in areas that align with current federal priorities. We heard earlier about nutrition education. Long before it became a marquee item of MAHA, we were leading the nation in integrating nutrition science into our medical education program. The average medical school in the country gives students 2 hours during their entire 4 years of nutrition education. We have pioneered that approach of our teaching kitchens. We have 4 teaching kitchens, and our students currently in the upcoming year will get 50 hours of nutrition education during their 4 years. That was not reactionary. That was what we've been doing for over a decade. So we do, again, have areas of alignment. We've developed curriculum, we've trained faculty nationwide, and we've built the evidence base for why this matters. So now that HHS and MAHA emphasize nutrition and preventive health, we're well positioned, not as followers, but as leaders and partners with expertise to share and support that initiative. I also want to emphasize something really important, which is the PhD pipeline. Graduate students and postdoc researchers are often described as the worker bees of academia, dedicating years in laboratories with the goals of one day leading their own projects. This hardworking group also represents the future of workforce for every biotech, pharma, and medical device company in the region and beyond. Nationally, we're seeing some deeply troubling trends as students have options, especially smart students, and they are sometimes choosing to go in different directions because of the current apparent horizon. Many universities have also begun to cut the number of PhD candidates they plan to accept in the current application cycle, and in fact, even in the last cycle. Some reports sadly detail how schools have planned to shrink those graduate students by a third or more, while others have actually paused PhD admissions completely. We know that more than 10,000, 20,000 we heard earlier, experts have lost their federal jobs in the last year as the shrinking of that federal workforce. At our School of Medicine, we've chosen a different path. Our PhD enrollment has actually more than doubled in the last 6 years and has grown by 30% over the past 3 years. And this year is no exception. We continue to grow it. We have no plans to reduce or pause it. In fact, we're continuing to support that pipeline of highly trained scientists at a time when others are closing, because we know that those students are an important part of the R&D engine for which both our institution and our companies that we work with rely on them. If you look at our graduate admissions data, you'll see steady growth in biomedical sciences, public health, and health informatics programs, and we're really finding that the talent level of the students is increasing every year. We recognize that the current climate is challenging, which highlights the importance of academic research, and we remain committed to that as the foundation for future health breakthroughs. If we don't continue to train these next generation and we make it increasingly difficult to recruit international talent through visa restrictions and increased costs, we risk creating a structural workforce shortage that will allow others to take our place, including China. Training these future innovators is one of our most important contributions to the economy. Finally, I mentioned briefly, but we have increased our clinical trials capacity and strengthened our partnerships with industry. We've more than tripled the size of our clinical research awards over the past 10 years. And we now conduct hundreds of clinical trials, everything from early phase investigator-initiated studies to large multi-center industry-sponsored trials. And that investment in our infrastructure, including data platforms, regulatory expertise, and patient recruitment systems, ensure that we remain a viable partner. We also focus on populations that reflect the diversity of Orange County and Southern California, ensuring that the evidence we generate is widespread utility. As you may have heard, we, in addition to opening the new hospital that Vice Chancellor Goldstein showed you earlier, we also acquired 4 hospitals in the Orange County and even LA County community. Hospitals that allow us to make sure that we have health equity as one of our foundations, but also allows us to make sure that those clinical trials include vast, diverse patient populations so that it actually has a real-world impact. Finally, I'll just briefly talk, I'd be remiss if I didn't address AI and large language models as they're reshaping everything we do, from drug development to clinical trials to healthcare delivery and patient care. AI, we know, has enormous potential and identify patterns in complex data and improve patient care. We started investing in our AI infrastructure, which mainly means people as well as equipment and data, 9 years ago in a major way. And it paid off really big. Just as an example, during the pandemic, we had a flood of patients. We ended up opening a hospital in our parking lot with a tent, and the entire hospital was converted to an ICU, essentially. Fortunately, we had some pretty brilliant scientists and physician scientists working and using large language models, using AI, and generating data from those patients that came in starting in early 2020, extending all the way through into 2021 when the real flood of patients came through in the wintertime. We were able to achieve the best risk-adjusted outcome in the country of any academic health system. So that shows you the power and the ability to save money and also improve lives by using that. So it really is important. But it's also important to be realistic. Just simply inputting medical records into ChatGPT is not going to solve our healthcare challenges. It's much more complex than that. Where do I think this is all headed? Again, I'm optimistic, as I said, but I'm not complacent. I'm optimistic because Congress has shown that it values NIH and research. NIH leadership is engaging with institutions like our own in ways that suggest they want to strengthen, not dismantle the partnership. Dr. Bhattacharya's visit here was substantive, collaborative, and forward-looking, which I think are good signs for a strong collaboration. Academic health systems like ours have to adapt, and we are adapting. Diversifying our funding, as I said, building new capabilities, and focusing our investments where we can have the greatest impact, not trying to do everything. We can't boil the ocean. But the underlying need hasn't changed. Patients still need new treatments. Parkinson's, among other diseases, are really important. Our industry partners still need a pipeline of ideas and talent that we can bring, and the innovation ecosystem still depends on the work we all do together. But again, not being complacent means that we don't allow this sustained instability to undermine the work we're doing. What we need is a new accord. We need federal agencies to provide stable, predictable funding and to implement reforms thoughtfully and slowly, not drastically and radically. We need academic institutions to demonstrate accountability, focus on high-impact research, embrace validation and real-world evidence, and train the workforce. Industry partners need to continue to collaborate with us, translate discoveries into products, and recognize that their long-term success depends on the health of our success as well. So again, at UC Irvine, we're prepared to be a leading partner in this framework locally, statewide, and nationally, and we are positioned to manage current uncertainty and to emerge stronger due to our resilience, our commitment to workforce development, and alignment with federal priorities, including nutrition education and real-world evidence. So I'll just close with the final thoughts, which is, as business leaders, the health of academic medical research is not abstract. It is your future product pipeline, your future workforce pipeline, and ultimately your competitive advantage. For students and trainees, there are still vibrant and meaningful careers available in biomedical science, whether in academia, industry, or government. And the challenges are real, but so are the opportunities to make a real difference. At the School of Medicine, we're committed to ensuring these remain accessible. And I want to just say to my fellow academics and healthcare leaders, we have navigated uncertainty before. We will again. We've adapted to new funding models, regulatory requirements, technologies, and scientific paradigms. We just need to remain bold, collaborative, and stay focused on advancing knowledge and improving health. As we train more students than ever, we conduct advanced research and partner with industry to translate discoveries. I see this not as a crisis, but as a pivotal moment. I'm confident that Orange County and our country will emerge from this period even stronger. So thank you. I look forward to questions and answers and continue this discussion with my fellow panelists. Thank you.
Hello and good morning. I'm Kirsten Axelson, and I'm really pleased to be with you all. I'm from New York. I spend a lot of time in New York and Washington, D.C., where we are home to very big mountains of gray snow. We're working on melting over the next few weeks. As I've mentioned, I've worked in the biopharmaceutical industry and now as a consultant for 25 years. So with that, I bring a bias, but I also bring information in that I have been helped decide on advancing or not advancing clinical programs, some of which could be promising to patients because the financial outcome was uncertain or negative. And I think we've all seen, especially in cell and gene therapy, how the financial reality of promising developments has meant a lack of continued investment or use. Some things are not affordable, or in some cases, the market is not willing to pay for certain treatments and they don't get developed. And so what I'm going to talk about is the effect of policy on drug development, on what gets advanced and also what gets used. Let's see. So, I always start off with living longer costs money. It is just, there's no way around it. Other than maybe vaccination, there aren't that many things you can do to get people to live longer that has a negligible cost. And you can say, oh, well, the US, we spend more on healthcare than any other country. Other countries spend more on education, which is highly correlated with longer lifespan, and on social support and housing. Living longer just costs money. If we want to continue to grow our crop of people who live longer, it's going to cost us money. And that doesn't mean we need to just keep spending, but it does mean we need to figure out how to do it the most cost effectively. And as we live longer, we have increased our demand for medicine, for hospital services, for physician services, and prevention and increasing lifespan and increased productivity often doesn't count as savings, right? We just look at what we're spending, and we are spending more on all of those things. Even when treatments with value expected to be greater than their price, such as medicines to treat obesity, such as medicines for hepatitis C, even when well-respected health economists would say, well, at discounted prices, those drugs are worth it, there's still spikes in costs that are difficult to manage, right? Like, unlike hospital and physician services, if you have a big breakthrough, there's pent-up demand, and you see a lot of spending, for example, go on untreated hepatitis C infections or now on multiple medicines to treat obesity. That's the way scientific advance works. We figure out how to unlock and treat a certain mechanism, and then there's a bunch of drugs developed, and spending goes up. Also, with medicine, unlike other parts of healthcare, spending goes down with generic and biosimilar entrants, right? There's no generic neurologist or generic radiologist, as there should not be, but there are generics in medicine, so it's a much spikier type of a cost projection. And also, just finally, as I started off by saying, whether you like it or not, the reality is that investment in drug development and the expectation of a financial reward is positively related. People will say, oh, well, you make plenty of money. They made billions on this drug. Well, that's true. You don't make billions on a lot of other drugs. But even if you're covering your costs, and having a profit, if an investor says, what's more interesting to me, semiconductors or AI, that's where the investment flows into. I mean, there's still blacksmiths, right? But people, by and large, are choosing other professions where they can make money or have a more predictable outcome. So just because you say that the finances, the outcome covers the price of the clinical trial, doesn't necessarily mean that investors will want to put their money behind promising inventions, many of which are developed in universities like this one, and incubated in small biotechs, which absolutely rely on investor income to be able to take that promising technology from an idea into patients, and ultimately to put before the FDA, where they hope to get approval. So political and economic factors are affecting medicine access and reimbursement. I think we've heard this from a number of our panelists, that affordability is a concern. While medicines are about 15% of all healthcare spending, what people spend out of pocket on medicines is about 50% of their out-of-pocket spending. This means that health insurance plans typically ask you to pay more of the cost of your drugs, a greater proportion of the cost of your drugs, than they ask you to pay for an emergency room visit or a primary care visit. So people really feel that. They see the price of the drugs at the pharmacy, they don't see the big discounts that are being given behind the scenes, and they're paying off of the list price. And it's a tragedy when someone has to leave a prescription at the pharmacy because they can't afford to get it. And that is a tragedy that needs to be dealt with. Constraining biopharmaceutical prices has popular support. These companies are seen as too powerful, too big, they're global. And then also, because there are so many new medications that treat very serious conditions, health systems around the world are not seeing specialty drugs as special, right? It used to be if you developed treatment for cancer or for Parkinson's or for Alzheimer's disease, well, you know, you'll pay what needs to be paid for it because there's no other options. Well, now with so many specialty drugs constraining healthcare budgets around the world, countries and health systems are making the decision to maybe not cover rare disease drugs. You see that a lot in Europe. A lot of countries are not covering drugs for rare disease because they are seen as too expensive, even though these patients don't have any other option. And finally, increasingly, we're seeing there is a local preference, and this is also being driven by the United States. They want to see manufacturing happen. Countries want to see manufacturing happen in their own country, which, you know, can be great if you're a country the size of the United States. It can be a bit more of a challenge if you're a smaller country asking for an investment, either in local manufacturing or in tech transfer or other ways to invest in the local economy. So we see this manifesting in a lot of different approaches to regulate biopharmaceutical companies and PBMs. I think you've probably seen this in the news, whether it's price controls, the popularity of the government intervening in pricing. There's scrutiny on mergers and vertical integration. There's lower trust in science and a lot of question. I think you've seen in the polling that people are questioning more vaccines, even and setting aside the COVID vaccine, but basic childhood vaccinations that have been sort of used for a long time. We're seeing those rates go down. And then, of course, also there is a popular interest in nationalism and really building up the manufacturing sector and retaining strong U.S. sectors. But at the same time, some of these other policies are really pushing companies either out of the U.S. to develop their technology elsewhere. So just kind of thinking about the distribution of global pharmaceutical profits, and in particular thinking about most favored nation pricing. So about 59% of all pharma revenue is outside of the US. That's revenue. About 80 to 90% of all profits are in the US. That is because there's been a big divergence in pricing. As prices have gone up in the US, they've gone down in other countries. Basically what's happened is in many other countries you have single payer systems. It's take it or leave it. So you go to that country and you say this drug is worth $10,000 and they say I'll give you $2,000. And many companies have said, fine, $2,000 is better than $0. And the US market has now become the engine of what drives investment, right? Like you think about your prices and you think about the market in the US. It used to be back when you do financial modeling, you would develop a forecast, and you develop the forecast for the US, and you multiply that times 1.2, and that's your forecast. It's kind of that sophisticated. Now you might multiply that by 0.9. With the risk of reference pricing. Launching a drug in Europe or Japan has become a risk to the US revenues. And I think we're going to see companies making decisions to not invest or not launch drugs outside of the US because of the risk of international reference pricing, and again, because these countries have become more and more constrained with pricing. We've seen a willingness to just not accept, to not pay for those medicines outside of the US. And when I talk to people who live, who work, or who make decisions in European health systems, they've said that's a decision we make, right? We provide, it's basic care for everyone. We provide great basic care for a lot of people. And if we can't afford to pay for cancer drugs or rare disease drugs, we just won't have them. There's too many drugs in the US anyway. Where in the US, we have typically had a very different approach, right? We want to have the best of everything, and we want to put everything behind people with a disease and give them the best shot. You know, there are pros and cons to both. But that's how sort of different orientations to healthcare have resulted in the US becoming an increasingly concentrated market for where you get your profitability if you develop a new drug. And this just sort of gives an example of what's been happening. Now, in the US, list prices have been growing, meaning like the sticker price you pay for a car at 8-9% a year or more. Net prices have been growing at far less than that, 2 to 3% in some cases, in many cases, or even negative in the case of like the insulins. This is because when drug companies go to make a deal with a insurance plan, often they can get placed on the formulary by giving a big rebate. The insurance plan can then use those dollars either to create programs that attract beneficiaries, like certain types of healthcare support, and that's the way that we have seen the prices in the US keep going up, in addition to pressure that's been put on by government expansion of government rebates, such as the 340B discounts and Medicaid discounts. European countries have benchmarks in place to ensure that prices keep going down, down, down. In Japan, the prices are also cut. They start off at a relatively higher rate relative to some other developed markets. And then there's other post-price restrictions, such as clawbacks. In some European markets, once you've spent, say, $100,000 on drug spending, then the drug companies are assessed back a certain amount of money. Like, you got to pay this as a tax because we've hit the ceiling of what we're willing to spend on drugs. Again, there's pros and cons to both. But it has resulted in, again, the U.S. market taking the majority of the share of the profit that sustain investment in new innovation. So, this president has said that's not fair. And also, it's bipartisan. I do not think it is going to be sustainable for drug companies, multinational drug companies, to have a price in the US that is quite different from their price in other developed markets. It's been seen, it can't be unseen. You can get that in two ways. You can bring down the price in the US, or you can just stop selling in other developed countries. As I've said many times now, US is 80 to 90% of the profits. Even big countries like Germany, Japan is the second biggest market outside of the US, it's 10% of all revenues. In many cases, you're better off just not launching the drug outside of the US than you would be in having to bring the US price down to match those very deeply discounted prices. I think we're going to see more of that. We've seen that the president has brought 17 drug companies to make a deal. And I think there's been a lack of clarity among many of us of what is in those deals, even though there are press releases. We did see when Trump RX was launched, we saw the pricing for some of those drugs. But in many cases, the consumer will not be seeing a big difference in their prices. In Medicaid, of course, there's not really much of a copay. And if prices come down in Medicare, again, as we've seen with the Inflation Reduction Act prices, some people are spending less, but some people are spending more as deductibles are going up and premiums are going up. So, I don't think there's many markets where you would say the government stepped in and set the prices and everything now is working great. And I would say the providers in this room would probably, you can challenge me on that, but would probably agree with that, right? It doesn't necessarily create the best incentives. Are drug prices wrong? Sure. There are plenty of times where drug prices are wrong. But then there's also, again, plenty of instances where health economists have looked and said, oh, we got much more value from statins, for example, than we ever paid for them because competition brought prices down or because of the health benefits. So I'm going to just go ahead and finish because I think I'm probably going to give Julie a heart attack if I keep going over time. So just finally, to think about how this may affect global drug development and investment in technologies coming out of institutions like this one that Dean Stamos just mentioned is very important, both to the economy and to the education and academic rigor that can be offered in these institutions. The U.S. has gone from being a leader, world leader in clinical development, in clinical trials, to now China has more clinical trials ongoing than the U.S. Many of them are in phase 1 and phase 2. And you could say, oh, well, those drugs are never going to get approved here with just Chinese data. Well, a couple of things can happen. You can do some trials here to increase your diversity. But also, I've noticed all the European countries where we've seen an exodus of clinical trials. Let's combine that with a most favored nation pricing policy that's likely to mean multinational companies won't launch in Europe. You could very much imagine that companies that are based in China that are developing drugs at a far cheaper cost, because you have a population that's large and willing to enroll in clinical trials, could easily step in and meet that need in Europe, get their drugs approved, get some additional data. So the combination of our pricing policies, the fact that we haven't invested as much as we should in making clinical trials less expensive to do here, means that there is another very strong option for the world's next leadership in biopharmaceutical development. Whether that's a good or a bad thing, I think we could debate or discuss whether the U.S. needs to retain their leadership position in clinical development. So with that, I'm done, and I look forward to continued conversation.
So alas, we only have a couple of minutes left, so I'm going to combine like my 6 questions into one, which is starting with, is all of this change a catalyst for another bigger full-scale debate? And I want to premise that by saying I personally think it is. I also see that, what drove the debate on the Affordable Care Act in 2009 and 2010 was frustration from stakeholders, largely from insurers and employers and doctors and hospitals and drug companies. I feel like what's driving this one is frustration, not just from the stakeholders who are frustrated, but from patients as well. So are we looking at another major debate in the next year or 2 or 3? I'm going to ask each of you.
Yeah, I think we are. But to me, I'm not sure the Affordable Care Act is the right sort of comparison, because I think even though that was huge in scope, compared to everything we've talked about so far today, that was like one little corner of the world. And so I think this is the next year or 2 or 3, but frankly, I think it's a conversation for decades to come. So many of these changes are so dramatic that I think I think we'll see that increase, especially if we see big changes in the midterms. But I don't think that this is something that in 2 or 3 years we'll sort of have neatly tied up and say, okay, this is our new normal. I think it's going to take us a long time to know what our new normal is.
So I think it depends what the objective of what you want to see a major change is going to be. So when I actually teach a healthcare marketplace class, which really ends up being kind of like an economic history class, and one of the big things that keeps on happening is we cover more and more people in the U.S., whereas everywhere else in the world, at least industrialized world, pretty much by World War I, everybody had national health insurance. And we have repeatedly blocked it, different actors, different times. People forget which actors actually blocked it, but that's where we are. So I'll just leave it at that. We'll stay abstention on that one. But one thing to keep in mind is that the political consequences are different. I sort of joked a little bit about the $5.1 trillion. Why is that different than leisure? It's because half of it's funded, or more than half of it's funded by taxation. And there's political issues wrapped into it because of all the states, agencies, the stakeholders, the institutions that are much more directly engaged, right? So Cornell has a hospitality program, but not every university has a hospitality program. So what I think we're probably going to see something come along the way, but a cautionary note, Dean Rosen showed it on that chart. If you saw it, where the biggest decreases in House membership is when a major health policy comes up and it passes, and then people are like, no. And so that
One
could
change, but not that change.
Yeah.
Exactly, and it gets hyper politicized in that particular environment. But all the scenes are set here. I mean, we have a macroeconomic issue. Medicare Part A will go bankrupt in about 3 years. There's not many things to fix about that. There's a question about underwriting, but we've seen all these things before, but it's not necessarily getting that much better. The only thing that the U.S. debt situation has that's better than everybody else's is our debt situation is better than anybody else's, and so we're less likely to see a major recession in essentially bond ratings compared to the rest of the world, mostly because of just demographics. But I would say, yeah, but maybe not the midterms. I agree. It's going to be coming, but it's going to be something for the next generation to deal with.
We're out of time, but I'd like to let our responders respond.
Sorry.
Just really quickly, I think the biggest threat is not to my world of academic health systems. I think the biggest threat is to the rural hospitals, despite the rural fund, and hospitals that are literally on a razor thin or no margin currently. And we have an access problem in this country with patient access. And if you visit pretty much any emergency department, you know that's a real issue, only going to get worse. That's, I think, the real threat that we have to face as a country. No question we have cost issues, but there's a lot of cost shifting, and there has been. You know, I laugh, I say, well, our health system, but that's why I laugh, because there is no health system in this country. That's the problem.
And I don't see that changing in the next generation. Even I don't see this country being one where we're going to have universal coverage. I do think this condition, you can hear me? The conditions are in place for a world where there's big health savings accounts and consumers are sent to do most of their shopping. I think Trump RX is an example of a condition is setting. I don't think this is going to happen next year, but I do think employers are going to say, here's a $10,000 HSA, go do most of your stuff there, figure it out. We might even see that in Medicare. And the consumer is going to be relied on to make decisions which not everybody is capable of.
Thank you all.
Thank you very much for a very interesting panel.